Hi, everyone. Thank you for joining us. I'm Vicki Goodman, and on behalf of the Friends of the Semel Institute for Neuroscience and Human Behavior at UCLA and the Resnick Neuropsychiatric Hospital Board of Advisors, it is my pleasure to welcome you to our Open Mind program with Dr. Thomas Insel, author of the new critically acclaimed book, Healing: Our Path from Mental Illness to Mental Wellness. It's truly an honor to have Dr. Insel with us today, joining us from his home in Northern California. He is a national leader in mental health research, policy, and technology, a psychiatrist and a neuroscientist. He served as director of the National Institute for Mental Health for 13 years, from 2002 to 2015. Dr. Insel, as well as all our preeminent discussants today, have very impressive and extensive bios. But in the interest of time, I'm just going to share a few key highlights and hope you will read more about each of these scholars on your own. After leaving the NIMH, Dr. Insel led the mental health team at Verily, formerly Google Life Sciences. He co-founded MindStrong Health, a Silicon Valley startup building tools for people with serious mental illness. And in 2019, he served as special advisor to California Governor Gavin Newsom, helping on behavioral health issues. We are also honored and proud to welcome back to the Open Mind Dr. Jonathan Sharon, who will join Dr. Insel in conversation. Dr. Sharon is the director of the LA County Department of Mental Health, where he oversees the largest public mental health system in the United States. He is a longtime well-being advocate who has worked tirelessly throughout his career on behalf of vulnerable populations. And to moderate today's discussion, we are honored to welcome back Dr. Thomas Strauss, Maddie Katz Professor at UCLA and Vice Chair for Clinical Affairs at the David Geffen School of Medicine, Department of Psychiatry. Dr. Strauss also served as the medical director of the Resnick Neuropsychiatric Hospital for 15 years. We would like to thank all of our preeminent scholars for taking the time from their busy schedules to be with us today to talk about how we can move forward on a path from mental illness to mental wellness. Before we get started, just a few housekeeping guidelines. Our program will run for approximately 1 hour, with the last segment reserved for your questions. If you would like to ask a question, we ask that you please type it into the Q&A, which is located at the bottom of your Zoom screen. As you can imagine, we have many listeners, actually 1,113 registered for today's program, and many questions, but we will do our best to get to as many as possible. Today's program is being taped and will be available for viewing on our YouTube channel, which you can find on our website, friendsofthesemelinstitute.org. There you will also find a library of videos from past Open Mind programs, a calendar of upcoming events, information about our Friends Scholar program, and our second annual Open Mind Film Festival for high school students that will be held on April 28th. You definitely want to tune in for that. For those of you with us for the first time, today's program is part of our free Open Mind community lecture and film series that brings together thought leaders in culture and science for meaningful and relevant discussions about mental health issues. As with public radio or public television, if you feel our programming provides an important public service, and if you are able, we hope you will consider making a donation in support of our programs. Information can be found on our website. And now, without further ado, please join me in giving a warm Zoom welcome to Dr. Thomas Insel. Thank you so much.
Thanks, Vicki. And gosh, what a pleasure to be here. Although I must say it would be easier to be doing this in person, and hopefully soon that will become possible. But while we're doing Zoom, I'll join you remotely. And what we thought might be best for today or for this evening's conversation is for me to take maybe 5 or 10 minutes at the outset to say a little bit about this book why I wrote it and what I hope it will do. And then we'll have Doctors Strauss and Sharon join for a broader conversation. So let me quickly say a little bit about this book, Healing. I hadn't written a book quite like this before. The idea of it came out of my experiences at NIMH and then experiences in the tech industry thereafter. And really the reason for doing it came down to trying to understand something. It's actually probably the best reason to write a book is when you can't figure something out, if you can take the time to sit and write it out and think about it. It's maybe a way to solve a problem. What was the problem? For me, I was trying to figure out why during my career, when we've had so much progress in science, in therapeutics, so much progress both in basic neuroscience and clinical science, we haven't seen that convert to better outcomes, particularly for people with serious mental illness. This really confused me because kind of at the individual level, I could see that people were getting better. And we were seeing individual therapists and individual patients feeling that they had made real progress. But at the population level, all the numbers were going in the wrong direction. Suicides were going up, morbidity defined as unemployment, early mortality defined as incarceration, homelessness, all of those things were getting worse, not better. In fact, arguably, they were worse in 2020, when I was working on all this, than they were when I started my career 40 some years earlier. I don't think that's true in most areas of medicine. I don't think there are very many areas of medicine where one would say we were better off in the 1980s and 1970s than we are in the 2020 years. But in this area, though individuals, I think, are definitely doing well, populations are not. And I wanted to try to understand that gap. And the first part of the answer came from trying to interview lots of people. And I kind of moved from being a psychiatrist and neuroscientist to being more of a journalist. Spent a lot of time traveling around California, but more broadly around the world, trying to figure out where we're at. And what I heard consistently from almost everyone I spoke to was that the mental health care system is broken. In fact, some people said it's really more of a mental sick care system because it's all built around crisis. It's all built in a way that focuses on some of the most expensive, most intensive care. Other people said it's not even a system. It's so disorganized, so chaotic, impossible to navigate. And I began looking at why that is and how that is. And some of the book deals with the history of how we lost the capacity for providing care in lots of ways. And it also looks at the solutions, how we can improve care. I focus on particularly sort of the quantity problem, but more than that, the quality issues of how do we ensure that we're providing the kind of care that we know will work, and what are the barriers to doing that. So the first part of the book is really describing this crisis that we're in and how in some ways it's become even worse through COVID. Second part deals with trying to understand how to fix the care system. The third part of the book, which I think we might talk about the most this evening, came out of, in part, a conversation with Dr. Sharon. I don't think he and I have ever talked about this, but it was on a visit to Los Angeles. We were chatting about that gap between progress in science and lack of progress in outcomes. And John said something like, well, part of this is that we're focused in the wrong places. And what I began to understand from conversations with John, as well as with many others, is that when we talk about mental health, we actually have to talk about more than mental health care, that we could actually fix the care system and still not be where we need to be if the care system is based on fundamentally a medical model, a model that's worked really well for infectious diseases and for many other parts of medicine, but maybe isn't the right model for people with serious mental illness. And what John was suggesting to me was we needed to think more about recovery. And when I asked him about what is recovery, what do you mean by that? He said, well, it's really simple. It's just the 3 Ps, to which I was thinking, well, you've got Prozac and you've got Paxil. And I was trying to figure out the 3rd P when he said to me, no, it's actually people, place, and purpose. If we want to really affect mental health, not just mental health care, we have to be thinking about the 3 Ps: people, place, and purpose. Social support, sanctuary where people can recover, that is having a safe and supportive environment. And the last one, purpose, really vital, that people have to have a reason to recover. They have to have a mission. They have to have something that they care about. And that actually had eluded me in much of my thinking about that original problem of why we hadn't done better in terms of outcomes. And I began to understand that while we do need the medical model, it's important. I mean, these are ultimately problems that can and should be defined medically in the sense that these are brain disorders. The solutions are actually much broader. And the solutions have to be relational, they have to be environmental, they have to be even political. And that we weren't really going to be able to have that impact that I was searching for in terms of population health until we get to a point where we're actually engaging on those 3 Ps. We're bringing in those other considerations and thinking much more broadly about recovery and how we get to that point, rather than simply trying to reduce symptoms and trying to figure out how to manage the acute crisis. So with that, let me invite Doctors Strauss and Sharon to join me. And I'd love to make this more of a conversation, particularly because John Sharon has been such an important part of my own thinking about how we're going to resolve these issues and how we can move forward. And Los Angeles may be an incredibly important incubator for making that happen.
Thanks, Dr. Insel, for a wonderful introduction. And I just want to say briefly that I think both you and Dr. Sharon are owed a debt of thanks from this audience and from the public, 2 career public servants who've done extraordinary things. So it's a wonderful confirmation of planets that you are here. So thank you both. John, I'm guessing that you had some thoughts as you heard Tom reflect on the book and honor you with being the 3 Ps guy. I just didn't know if you had any initial comments you might want to make.
Well, first off, it really is an honor to be invited here to be with you and this audience tonight. And I think Tom has really put together a fantastic book, and I hope a lot of people get to read it. I think it'll influence the way that we think about mental health. It'll influence the way that we develop policies, and hopefully transform a system that truly is broken for so many reasons. And I'm assuming we'll get into some of them tonight. With respect to the people, place, and purpose, sometimes I teach, and I am a psychiatrist, I'm a neurobiologist, and when I speak to students about people, place, and purpose, they sometimes think that I'm a bit astray. Let's talk about some pharmacology. Let's talk about some neural circuitry. Medications, I think, as Tom has already articulated, really are great tools, but they are tools. And one of the things that is a big challenge for mental health outside the other medical disciplines is the engagement piece. We spend so much of our time trying to engage people in care and to keep them in care. And that's very difficult for people, particularly suffering from severe and persistent mental illness, many of whom are not aware that they have an issue that needs to be addressed. And some of whom have been engaged by a system that's been toxic and traumatizing. So those are not good things when you're looking for engagement. I'm a street psychiatrist on occasion, and it's not always a simple dialogue. We have to spend months to get people to really consider coming into the system and accepting care. And that's just not the case elsewhere. But the funding that we get, as an example, in California, in the counties, is a fee-for-service model where we see somebody in a clinical environment and we bill by the minute for clinical care that's defined by the federal government. So where's the engagement? Where is the funding? Where are the resources that we need to get someone to say, hey, this could be good for me. I trust this person. They're not just throwing medications and clinical interventions at me. I will say the state, with the acclaimed reform of Medicaid, is making a move in that direction, but it's nowhere near where it could be. And a lot of that really ultimately comes back to people, place, and purpose, because everybody needs people in their lives, whether it's their family or other supports or kin. Everybody needs a place to live that's dignified and comfortable, and places to recreate. And everybody needs a purpose in life. What is the point of recovering? What is the point of doing well if you don't have meaning and goals in your life? And if we're not embracing those fundamental aspects of the human condition, we're missing the boat.
Well said, John. I think each of you, Dr. Insel in the book, and John, I know from conversations you and I have made a point of going places and visiting cities and environments where a different approach to the community care of people with serious mental illness has been embraced. The example of Trieste, Italy comes up over and over again, and there's a wonderful section in the book that addresses that explicitly. Since not everybody listening knows about that, I wondered if perhaps, Dr. Insel, you would like to give an overview, and maybe we could talk a little bit about what works there and what might we learn from that in a place like Los Angeles County.
Well, we could, and both John and I know a little bit about this. It's still very much in flux, by the way. Not clear what the future of the Trieste program is, but this goes back to the 1960s, late 60s, when the Italian legislature essentially outlawed institutionalization of people with mental illness. And so the nation really needed to develop community supports. Of course, we went through something like that in the 1960s in the United States as well. But when you look at our community mental health system, only about 10% of the people who were treated in our community mental health system had what we today would call serious mental illness. 90% were people who would not have ever ended up in an institution no matter what. In Italy, it was a different story. They really took this on. They talked about hospitality instead of hospitalization. And they built out a number of community supports to ensure people had housing, had supported employment. They put a lot of their investment into ACT teams and into making sure that they could get to people before a crisis or early on in a crisis. And they're essentially able to provide a lot of what we had always aspired to here in the 60s, but a true community mental health system that allowed people to recover. It gave them the range of supports they needed, gave them the time they needed. And also, I must say, created a culture that valued this kind of care. In a way, I tell the story in the book about how when I was leaving Trieste, I jumped in a taxi to go to the airport, and I had a driver who spoke really excellent English. And he started giving me a tour on the way, showed me all the things that he was so proud of. And at one point he points up the hill and he says, up there is, our is San Giovanni, which is the clinic, that's their mental health clinic. And he said, smiling at me, he said, we have the best mental health care in the world here. And I thought, I've never had a Uber driver or a Lyft driver or a taxi driver in Boston or San Francisco or Los Angeles say that to me. I can't imagine. But that was a huge source of pride in Trieste, that they had built this in some ways for those who were the greatest in need. They wanted to define who they were by how they cared for those who really couldn't care for themselves. What a wonderful statement of how they identified themselves as a city. But John was there as well. I mean, probably been there more times than I have. You may have a sense of what's different as well.
Well, Tom, I think your descriptions are really resonant with me and with the experience there. Now, this concept of radical hospitality, which creates an environment that feels safe, it feels welcoming. And that's what you want. You don't want to be in places that don't feel comfortable with people who are too busy to actually pay attention. And as far as the community mental health centers that were built, that Tom describes, they're centers of gravity for people who have significant needs. There's 24 access to get help, and to get food, and to be with people that are friendly. Not do I have an appointment? Yeah, you have an appointment. I'll come in for a visit to see a psychiatrist, and try to have a overworked team, do some case management, maybe some psychotherapy if you're lucky. They also have beds, housing options for people that, for whatever reason, need a place to rest. And I think rest and respite are really core features. There's also in the community mental health center model, what are called social cooperatives. Here, I like to call them peer enterprise, where individuals can actually do things that are not only meaningful and require skills that are developed, but they can generate money for the site, for the individual. Artwork is sold, products are made. I brought a bunch home because they're great, and I gave them to people for Christmas. The issue of inclusivity with respect to the culture in the society is absolutely critical. And I may be wrong about the history, but my understanding really is that JFK was the one who declared that asylums were inhumane, and really asked the world to deinstitutionalize. And some parts of the world did it. And they did it responsibly, where they built up communities, not just with treatment for people with disabilities, but with other aspects of human need. We tend to call them the social determinants of health. I mean, for me, it's all about well-being. Beyond that, and they responsibly let people in the community understand what was going on and why, and got them on board so that it was a collective partnership. And when the asylums were closed, they weren't just emptied out. It was done gently. Here, in future administrations following JFK, the doors were open, the investments in the communities was not made, and we moved from what we had at that time, which were the mental health institutions or the asylums, to the outdoor asylums of the street and the closed asylums of the jail, which are less humane and are different types of institution. And unfortunately, because we're so far behind, decades behind in terms of our investment as a culture and a society, and in terms of treatment resources and the resources that are needed to address the social determinants of health, it's going to take a long time to get there. And that requires policy and funding decisions and recognition of parity laws at the federal and state and local level, political will that I think is evolving. And I have to salute my bosses, the 5 supervisors of LA County, who are putting their shoulders down in many, many ways to move it. But we have a long, long way to go, and we are struggling, and people are suffering. And if it weren't for the individual efforts of people working in the public system, and I here also want to recognize the staff in my department and the contractors who work day in and day out. If it wasn't for heroic personal efforts, we would have even less success that we have right now, and we need so much more.
John, I'm really interested in how you are dealing with a lot of the same issues in LA. Yeah, I'm not sure Trieste is ever totally translatable in the US context. There's just, it's a small city. It's got different issues. It's a different culture. But when you look at, the 10 million people that you're responsible for in LA County and the range of challenges, what are you most hopeful about? Where do you, because there's a lot happening right now, a lot of moving parts. Where do you see the greatest promise for change in the next, let's say, 3 to 5 years?
Oh, that's a great question. I mean, what gives me hope, is the recovery of individual people. We've developed a street outreach program, the Homeless Outreach and Mobile Engagement Team, the HOME team, which engages people who have been homeless for years and decades, and does everything with guaranteed resources, including different types of housing and treatment 24/7 and access to residential treatment beds in real time, to get people off the street. And very recently, we had a woman who had been homeless for 33 years engaged by this team. And she now is housed and she's engaged in treatment. If you ask me what do I have hope about in the next, let's say, 5 years, I would say our development of an alternative crisis response system, which is a major focus of this department, multiple departments and the supervisors, as well as the state and the Fed, which you know, Tom, very, very well, both Toms. So that we can respond in real time to individuals who are deteriorating and decompensating and in the acute phase, and prevent them from falling out of community into homelessness, or in many cases being engaged by law enforcement and incarcerated. So much to do in terms of coordinating how we field crises that are occurring, how we go out in a health and human service response way as opposed to law enforcement, how we engage people with lived experience as a part of that solution, and then, in some cases, transport them back to home or to a boarding care, and in others to an urgent care or to crisis residential treatment programs, in some places to a hospital. But that is an area where I would say LA County is probably at 20% of the capacity we might need. So we have all of the different components. We have crisis response teams that are health and human service, mental health oriented. We have co-response teams with law enforcement. We have different call centers which alert and triage those teams. And we have the urgent cares that I had mentioned, the crisis response, the crisis residential treatment programs that I've mentioned. And we also have peer respite, but they are dotted throughout the county in a way that is not near capacity or well coordinated. And I've had the honor with others, including Judge Songhai Armstead, who's running the Alternatives to Incarceration movement for the county, to lead the effort around alternative crisis response. And 5 years from now, we're going to have double, triple the number of responders, with an emphasis on health and human services and receiving facilities to take them in and help people reconstitute in the short run and return back into the community, and then instead of ending up in the asylum.
Yeah, I'm with you on this. I think I would probably say, and people often ask me, if you could change one thing right now, what would you change? And, there's a part of me that starts where you started our conversation, which is around engagement. And, one of the things I think I learned in doing the book was that part of the reason we haven't had a greater impact on population health is that most people who need care are not in it. And those who need it the most are maybe the least likely to be in care, at least in the best care. So I get that, but I think in the short term, if I'm asked, what do I want to fix right now? it would be the crisis response and how we do it. We're 90 days away from the congressional requirement of having a new call number, 988, replacing the 10-digit suicide prevention lifeline number. 988 is not 911, it's something very different. What gives me concern is that the 988 was always, to me, an opportunity, kind of like a Trojan horse, really, to change a whole bunch of things that are urgently need transformation. And that falls into 3 buckets. It's who you call. So it shouldn't be 911. It shouldn't even necessarily be the suicide prevention lifeline. It shouldn't even necessarily be a call, but it could be text, it could be chat, it could be lots of ways of accessing telehealth. So it's someone to call, someone to come, and LA already has those mobile crisis vans. I remember when you and I first talked about this and you were putting it in play, and I was so excited that you were going to get that on the streets, and it was happening. And then someplace to go. You need to have, whether it's psych ERs or drop-off centers or crisis stabilization or crisis residential or peer respite, whole range of different models, but you need all 3 of them. You need that continuum. By the way, that is what we have in Trieste. It is what we have in parts of the US. I think we've done a pretty good job in Phoenix and Tucson and Denver and Austin. So some places have got this in place. I don't think we're there in very many parts of California. And so we're 90 days away from at least having the new phone number, but we're a lot further away from having the continuum of care that we need. And this will take building out the capacity for every part of those, just the way you said, John. I think we've got pockets of excellence, but we're not yet connecting the dots in the way that ensure that people don't get incarcerated, they don't end up crowding a medical surgical ER, they don't end up with a tragic encounter with law enforcement. We know how to prevent every one of those things if we do it right, but we're not quite doing it the way it needs to be done yet. So we're on a path, but a lot of work to do to get to where we want to be.
I wonder if we could touch on one of those dots that you just alluded to, Dr. Insel, that should all be connected, related to the whole topic of voluntariness versus compelled treatment and the complexities. And I know that there are many family members and friends of folks with serious mental illness likely on this call who have been bewildered and frustrated by how complicated it can be to help someone get access to care who, as Dr. Sharon pointed out earlier, may not even acknowledge that he or she has a problem or an illness, and or who affirmatively doesn't want to be treated. California was in the 60s a pioneer in creating legislation that was at the time felt to respect the rights of the individual to not be intruded upon by the state. There are many who feel that we've taken that too far, and that there are many folks who would lack capacity to make decisions of any kind about their medical care. What's the progress on this? What do we see coming? What might be some models for how to do this differently?
Well, I'll say a little bit, and then I'm going to turn this over to John, who's really an expert because he's dealing with this every day. I think the first thing to say is that nobody has the perfect answer. This is a very difficult and in some ways inescapable problem. And it's just the way you said it, Tom. I mean, you're dealing with people who, as part of their illness, don't think they're ill. So you've got, a problem that we don't actually see very often in the rest of medicine. But serious mental illness, almost by definition, involves thought disorder, involves a lack of judgment or a loss of judgment, a loss of insight. That's the core of the illness. And there is no escaping that the only way to treat that illness sometimes is to do it without somebody consenting or somebody volunteering for treatment. We never want to be in that position, because the other thing, as John said at the beginning, if you're trying to engage somebody in care, you've got to build trust. And treating them involuntarily immediately can destroy that trust. So ideally, I often say this, ideally you want to be upstream from a crisis. You want to be upstream from that moment. And in some real way, every time there is a crisis, we have failed, right? We have failed to get to somebody at a point when there was a way to work with them, when they had enough insight to understand that they in fact needed care. But we've got to reckon with this very difficult situation. I'm sure a question will come up later about the care court proposal, and that we now actually have a bill that has been dropped on the care court. This is a proposal. It's very much part of a discussion. The governor has said he wants to have an active discussion over the next several months about what this could and should look like. But I don't know anybody who thinks that we have the right system right now. I'm not sure there's anybody out there who would say, we figured this out and we're doing exactly what's best for all concerned. And so the care court proposal as it stands may not be perfect, but at least it's beginning the conversation that I think we needed to have for a long time in California about what we can do to do better by both the person who is disabled by their illness, and we could even say gravely disabled, as well as by the family, by the and by society writ large. So we need that conversation. We need to figure this out. But I don't think avoiding it, and I don't think assuming that the LPS Act as we've had it is the perfect solution. That's not where we need to be in 2022. I want to hear what John's thinking about this as well, because he's got to deal with this every day.
Yeah, Tom, I'm in general agreement with you. And if you take a step back, this is really a challenge of figuring out how to respect the need for autonomy and at times paternalism. On the autonomy side, we want everybody to be autonomous. We want people to recover and to make their own decisions about their lives and their care. On the other side, there are families that are destroyed and people's lives who are squandered, and public health and public safety risks in some cases because we are unable to engage and intervene. The way I really think about it is kind of a three-legged stool. First of all, what's the standard by which we would ever consider infringing on someone's civil liberties? We use now grave disability, the ability to provide food, clothing, and shelter. Well, food, clothing, and shelter are in some cases hard to interpret, and the person's ability to provide them. If you ask different clinicians or different first responders or even different judges or juries, you're going to get a different perspective. So it's not clear. But what is clear, I think, from a humanitarian perspective is that if an individual is not living safely in the community, as indicated by food, clothing, and shelter, the inability to provide or get access to medical care, the inability to kind of defend oneself safely and securely in their living environment, which unfortunately in many cases is on the street, and they're unwilling to accept care and resources are guaranteed and provided, we have a humanitarian responsibility, duty, I would say, to do something about it. So living safely in community as a standard, I think, is a good one, and we ought to define it properly. And it ought to be defined in large part by people who know it best. And those are the individuals who have not lived safely in the community and have actually recovered. The second thing is, when someone's not living safely in the community and they're refusing care or unwilling to accept treatment, how do you engage them? And it can't be an all or none. It can't be the relentless engagement of the home team like I had described. And if that fails, you go to a conservatorship where there's a surrogate decision maker for up to a year and then renewable. There has to be a continuum. We talk about continuums of care, Where are the continuums of engagement? And what I call the tools of engagement. And really the care courts, I believe, are introducing that. And we've been pushing for it in LA County and also with the Steinberg Institute, which Tom is a part of the Steinberg, it's on the board. So that things like shared decision-making, psychiatric advanced directives, really creative use of the temporary conservatorship, and also obviously the AOT program. So that you're gradually intervening and infringing on someone's rights gently as possible, just like using the least restrictive environment for care to engage them, with the goal 100% all the time of having them move towards more and more autonomy and not needing any type of an engagement tool except their own decision to engage because they need help. So with a continuum of tools and a better standard, I think we have an opportunity to reform the way that we get care for people who are unable to manage their safety in the community. But most importantly, across the board, you can't take or infringe upon civil liberties without guaranteed resources up front. So if you can't guarantee someone a place to live, housing, treatment 24/7, and we provide that in California. There's a program called the Full Service Partnership, which we tried to re-engineer here in Los Angeles County with a lot of help from UCLA, as well as the Balmer Foundation, Balmer Family Group, and access to treatment beds, open treatment beds, which we don't have nearly enough of. If you come with what we call on the home team, the home platter, and you offer that week after week after week for months and months and months, and someone's unwilling to engage and they're suffering and they're deteriorating, not living safely in the community, we have to kind of step it up and use an engagement tool to advance their opportunity to get resources and to recover. So I do believe if we can make the commitment and double down on resources and quality resources and resources that people are going to accept and embrace and get help from on the front side, then we have a chance to reform the mental health system and deal with the issue of compelled engagement and treatment.
So John, I struggle with this in the book, and there's a whole chapter around just these issues. And where I come down at the end of the day is actually not that far from one of the concepts in the care court proposal as it was originally written, which I would call a kind of two-sided mandate. It's a really interesting piece of this that most people haven't looked at. Everybody's looking at kind of the civil liberties issue. But the other side of it, which you're referring to, and I think hasn't gotten enough attention, is there's a mandate to provide care. It's holding counties accountable for providing all of the stuff that people need. It's real in some ways. It's more stringent about counties than it is about individuals, and that's a piece of this which I think reflects the sense that we can do more. We as the state, we as counties need to be doing better by those who have A, schizophrenia, and B, are homeless, which is precisely the group that is dealt with here. And basically it's saying, you know what, incarceration and conservatorship, those aren't the answers. We have to use this new tool to prevent those. And that's not the way I think it's been framed. I don't hear a lot of people talking about it that way. But as I say, I think we're in for the next several months of conversation about what we want this ultimately to look like. And my hope is that we're not going to end up where we are now. I think we need to do better than what we've been doing in California.
No, I would agree. And I mean, one of the things that I've seen evolve, which is disappointing, is the loss of guaranteed housing in the formula. At one point, I thought that the state was guaranteeing the housing as well as what are called the supporters, the people who are working with an individual who's in the care court.
Yeah, the navigators or supporters, that was going to be a really key part of this. And I don't know that again, we have a bill that's been dropped. There's going to be a lot of conversation. The bill is a first proposal. I'm
Yeah.
sure it will be altered in all sorts of ways.
Yeah, I have one.
Those
I
are
have
two
to say-
critical pieces.
I do have to say, the other thing here is that, beating up on the counties, and I know this because I'm at the county and I get beaten up constantly with sanctions is not helpful. We need facilitation at the federal level. We need facilitation at the state level. We have systems that are so constrained by reporting and audits and taking care of medical charts and not human beings. When are we going to change that? When is a director like me going to be held accountable for outcomes and given the resources that I can use flexibly to achieve them, whether it's housing or treatment or other issues that are helpful engagement and long-term recovery? I mean, tell me to get 10% of the homeless people with severe persistent mental illness off the street each year over the course of 5 years, and the funding that is needed flexibly to do what we know we need to do on a day-to-day basis with an individual, and then you achieve 8% or 10% or 12% or whatever. That's the accountability. Not, did you bill with the right code, and are you bringing down enough money on a minute-by-minute basis, and are you going to find out whether you did it properly 3 years later because of the audits? And when you haven't done it right, you get punished and you end up giving $50 million back to the state. That's not helpful.
Amen, brother. I mean, this is really, I think this is a key issue, and I'm glad that this conversation has surfaced this, because we really are going to need eventually to move to an outcomes-based system in California and across the country. And we're going to need Medicaid, Medi-Cal to do that. We're going to need private insurance to do that. It's already happening in primary care. It's happening in lots of areas of healthcare. But behavioral health, like in every other way, is so far behind. It's going to require us really defining what are the outcomes that matter, and then holding ourselves accountable to delivering those, and then finally getting the kind of alternative payment models that incentivize outcomes instead of incentivize the kind of fee-for-service time spent that we're doing now.
Perfect time to invite Vicki back on to read some questions from our participants.
Well, before I do, I want to thank you all. This has been such an informative and an enlightening conversation. And I just have to say how fortunate we are to have such passionate, dedicated leadership in the mental health field. It gives us hope that things are going to improve. So thank you, Dr. Insel, Dr. Sharon, Dr. Strauss. Very grateful to you. We do have a lot of questions. First from Javier. How does the reality of mental health disparities factor into this perspective in light of differential social determinants of health?
Well, I think we both will probably comment on that. One of the things that I talk about in the book, and if you get the audiobook, you'll get a slide set that goes with it that I wasn't able to actually publish in the book because they didn't want to put in lots of graphs and tables. But I actually look at what the disparities look like for people with serious mental illness. It's been a rather provocative statement, but unfortunately it's true. That if you compare various racial ethnic groups for issues like early mortality, unemployment, violent encounters with criminal justice, and rates of incarceration, sad to say that people with serious mental illness fare much worse than any racial group, any ethnic group, any minority group in the United States. In some sense, they are really our untouchables, and we haven't reckoned with this. We talk a lot about health disparities without often recognizing that the people who have serious mental illness probably have some of the most severe health disparities in the nation. And if they die 15 years earlier, that's about a decade earlier than any other group recognized by race or ethnicity. So one of the things I wanted to do in writing the book was to call out that issue and to ask for a national reckoning, that just the way we're having this reckoning now about Black Lives Matter and about the disparities based on race, we need to have at some point a reckoning about the disparities and the injustice based on having a brain disorder. Abraham Lincoln said, 120 years ago, that melancholia is a misfortune, not a fault. Melancholia being his way of talking about depression and mental illness. We seem to have forgotten that, and today it's really treated as a fault and not simply a misfortune that can be treated.
Yeah, I mean, I agree fully with Tom. And the structural inequities of our communities, and our culture show up in many ways, and they certainly show up in the realm of mental health treatment and in terms of access to housing and access to jobs. And those are things that are going to require relentless efforts and focus on fixing. So I look at them as I look at the inequities that and the disparities as simply more indicators and red flags that that our society leaves many people, many populations disenfranchised, and they suffer and they die early. For example, an individual of color is more likely to be diagnosed with a certain mental illness than others, and the treatment that's delivered in some cases based on lack of access is not going to be as comprehensive. We have to fix that. That's an active process that we're trying to engage in the Department of Mental Health, and it's not easy. I mean, part of the reason it's not easy is because we are absolutely overwhelmed by the demand, and our supply is limited, and our flexibility with the resources we get is constrained, and people are burned out, and we are losing staff. We're losing capacity as we need to grow it.
Yeah, I think where it really plays out is the double jeopardy. Being a person of color and having a serious mental illness puts you in an extraordinarily difficult position. One last story, then we'll go on to the next question. Dan Gillison, a friend of mine who is the executive director, CEO of NAMI, National Nights of Mental Illness, African-American man, said to me recently, if someone in my family has a mental health emergency, who am I supposed to call? I'm not going to call 911. It's just too risky. I don't have anybody to call. And it was at that moment that I really, it really occurred to me how this plays out in a way that it just calls out for the need, as John and I were saying, for a new system for crisis care. We have to rebuild that. And 988 isn't fully the answer, but it's the beginning of an answer. It's creating a system of crisis care that doesn't involve a police with guns and doesn't play into a whole series of potential risks that we need to avoid.
Dr. Strauss is the former head of the Resnick Neuropsychiatric Hospital for 15 years. I wonder if you would comment on that question as well, from your perspective.
Well, just to say that we contend, of course, with this unfortunate fact that the psychiatric inpatient bed has become an endangered species over the last 50 years in our country. Dr. Insel does a nice job of comparing the public health recommendations for beds per 100,000 with the actual numbers. And ironically enough, California is down near the bottom of the rankings across the country. But one of the challenges that one encounters, even if one works in a system or in a place where there is the resolve to address that by building either inpatient or day hospital or other facilities, is this sad NIMBYism that is so frequently encountered. I think it's many people in our culture still would prefer simply not to think about serious mental illness. One becomes aware of the need for services and facilities when one has a crisis or when someone one loves has a crisis. And then, of course, it becomes one of the most important things in defining one's world. But that sense that this is not all of our responsibility, it's only the responsibility of those in crisis, or that these are reflections of, to borrow from Lincoln, moral failures as opposed to brain disorders, is not simply another one of the huge challenges we face. So.
Thank you all. We have a question from Randy. Dr. Sharon, I am wondering if you've heard about Clubhouse international organizations. She goes on to say, I know Dr. Insel has. Our model embraces the 3 Ps that were mentioned in an outpatient social rehab program. Our data shows significant effect upon rehospitalizations for those living with serious mental illness.
Yeah, I mean, I'm a huge fan of the Clubhouse and the social cooperative. And we were talking about Trieste and what we're trying to put in place in Hollywood. In our Hollywood 2.0 program has the Clubhouse as a part of that center of gravity that I had been describing. And you know, when we talk about beds and the number of beds, now the number of beds, when you have an incredibly inviting, welcoming, comprehensive system where you can get what you need and you can be with people and you can pursue meaning and purpose, the number comes way down. You don't need a lot of beds in Trieste. We need a lot of beds here because we're so far behind building up communities for high quality, welcoming, culturally competent treatment and addressing the social determinants of health. I mean, the 500,000 units short of affordable housing in LA County it's a metaphor for the rest of the lack of investment we've made for those who have needs and you know don't have. I do want to say a few things more about the beds, though. I mean, we probably, based on studies that my department's done and RAND has done, the state has done, that an organization that we're working with right now around crisis response has done, we have at best half of the beds that we need, but it's not all acute care beds. We need beds for people that are longer term, and we need unlocked beds, and lots of them, where people can go and feel okay about going when they really need help. But we don't have the resources for that. We don't have the flexibility. We have these different pots of money that are kind of dropped on us with certain requirements, and they're fenced. And they make it very, very difficult for us to set up a system that is responsive in terms of you know, supply and demand. So I think when we consider the number of beds that are needed, we have to recognize that if there's a certain need for a certain number of acute and subacute locked beds right now, as we build up the community more and more and create more inviting, engaging programs and care, the number of beds will come down and the number of locks will come down. That would certainly be my hope. And I have to say that, you know, the families that are torn apart by the systems that are in place right now, which were so fragmented and inadequate, is hard to witness. I mean, I can't tell you how much my email and my phone blow up every day from families who can't find their, you know, child because of a mental illness, don't know who to call, find them in the jail, need a conservatorship. And when we have a medical field that is evolving, and Tom alluded to this earlier, because we know that people need, you know, transfusions, for example, if they have a certain type of illness, we have to double down on mental health in the same way. And with the building acknowledgement and awareness of how important mental health is, with the pandemic and other stressors that are really global right now, if we're not getting that memo today, you can't be a good family member, you can't work well, you can't teach well if you're a teacher, you can't learn if you're a student without mental health and emotional well-being. We're never going to get that memo. So it is time to align, it's time to simplify these siloed systems and empower the trenches and the people who need help, or else we're going to see more and more of the same, with people being institutionalized and the need for more and more beds And you can't build enough beds when the systems are not in place.
Thank you. Thank you for sharing that. We are out of time, but I want to ask each of you, and I'm going to take this from Tom Strauss's very adept monitoring always of our programs. Dr. Sharon, you shared your hope for the future. Dr. Insel, your hope for the future.
So I am hopeful. I mean, the book is hopeful, and it's hopeful because we actually know what to do. My hope is that we'll make the commitment to do it, and we'll do this in real time. I want my grandchildren to have a better world, and that means that we start taking care of those people who need care the most. And sometimes that may be even when they aren't ready for it. Sometimes it may be focusing on prevention, but we need prevention, recovery. We need this whole new model. We know how to do every piece of that. Clubhouse is a great example. So I'm hopeful that if we can start doing what works and that start doing the things we know already, we can get much, much better outcomes at scale.
Thank you. And I'll just reiterate that with dedicated leadership like you and your passion for improving the system, I think you give us all hope that we will have a path from mental illness to mental wellness. So thank you all for sharing your time. Thank you for giving us the opportunity to learn from you. And I hope that everybody has found this discussion really worthwhile and informative. I want to thank everybody that joined us today and hope that you'll return for more Open Mind programs. Please don't miss the Open Mind Film Festival. You will see the work of the next generation of filmmakers who are passionate about mental health. And that is on April 28th, 5 p.m. right here. Please join us. Thank you so much. Have a good evening. Bye, everybody.
Thank you.